Hello and welcome to the 2015 CROI. I'm Christopher Brennan here with IFARA TV, and we're really lucky today to have with us Andrew Grulich and Christine Khosropour. Andrew's from the Kirby Institute University in New South Wales, and Christine is from the University of Washington. We're going to be talking today about their work and what they've seen at the CROI broadly, which is kind of exciting. And today we're going to be focusing in their work on serosorting and seroadaptive behavior. So I'm going to let you guys do a little bit of introducing for yourselves, say who you are and what your work is about. So Christine, why don't you start a little background and then what you're presenting today.
Sure. I'm currently a PhD candidate in epidemiology. My work is in HIV prevention broadly among men who have sex with men, with a focus on understanding sort of the risks and benefits of serosorting and seroadaptive behaviors. So what we're presenting today is a study that we did here in Seattle at an STD clinic in Seattle. It was a retrospective study, so we used medical record data from the STD clinic here in Seattle between 2002 and 2013. And we identified men who tested newly positive during that study period. And what we were interested in is how serosorting and other seroadaptive behaviors changed before and after men are diagnosed with HIV. And sort of the take-home point of our study was that we saw the same proportion of men who serosorted while they were negative, so about 30 to 35% of these men while they were HIV negative serosorted, and about 30 to 40% of the men serosorted when they were positive. So pretty consistent proportion of serosorting going on before and after HIV diagnosis, and this was, we followed men out for about 4 years after they were diagnosed. And so sort of what we concluded is that, at least in our clinic, among men testing newly positive, they modified their behaviors based on partner HIV status, sort of maintained the same level of serosorting, and that sort of shift in behavior had sort of the broad potential to reduce HIV transmission to negative partners.
Interesting. Yeah. And Andrew, what is it that you were presenting today?
So I'm presenting on an interim analysis of a cohort study we have going on in Sydney, in Rio in Brazil, and in Bangkok. We've got about 250 serodiscordant gay couples enrolled in the study called Opposites Attract, and we're about nearly halfway through the study at the moment, so we're presenting our interim analysis. And what we do is we enroll serodiscordant gay couples and we follow them through time. We're just recording their behaviours, we're getting the negative partner tested at the same time as the positive partner comes in for his monitoring or his treatment, and looking at rates of transmission. So of course in this era almost everybody's on treatment, and we're finding that in the couples on treatment we're seeing absolutely no transmission from the positive to the negative partner. So it's really more confirmatory data that treatment as prevention seems to work in gay men. We've known for a long time it works in heterosexuals. Last year at CROI we had the partner study which suggested that it works in gay men, and this study really backs that up, so it's good news.
Right.
But I should say that the study hasn't been going long enough. We've got about 150 couple years at the moment, and that means the confidence intervals, the certainty we have about these estimates, is not yet enough that we can be really definitive to say, you know, it's really safe not to use condoms when viral load's undetectable. The study's ongoing. The partner study in Europe is ongoing, and that will mean we'll have data from both developed and developing country settings about this. But we really do need a couple more years' data before we can be really solid about that.
And it's so important to reaffirm and keep alive the concept that treatment as prevention is important, does work,
Yeah.
and that everyone should be focusing on that and including it in their lifestyles as they are living them. And so you were saying that 30 to 40% of your retrospective cohort was in both the positive and negative groups. Why do you think that it's is it important that they're both serosorting about the same?
I'm not sure if it's important that they're about the same. I think it's important to sort of reaffirm that it's a highly prevalent behavior. And actually, in another study that we've been collecting sort of serosorting type data in our clinic since 2002. And if you look at the trends in serosorting over time, they've increased pretty substantially from about 10 to 15% of HIV negative men who were serosorting in about 2002 to about 30 to 50% actually, depending on what site you're looking at. So at a community-based HIV STD testing center here in Seattle, about 50% of all HIV negative men in that clinic reported serosorting, and at our STD clinic it's about 30, and for HIV positive men it's increased as well. So I think it's more of a reminder that this was an HIV risk reducing strategy that was really born out of the gay MSM community and gay communities, LGBT communities, years and years ago, probably 10, 20 years ago, and it's really sort of taken hold as a risk reducing strategy over time. So I think in our study, the proportion serosorting is reflective of the time period that we chose. We kind of averaged out over that time period, which is about 30%. But it's just interesting to think about how this has really taken off as a strategy, and different implications for both. So for HIV negative men, it can be a risk reduction strategy, and it's certainly a strategy that's available to men for whom consistent condom use is not realistic and not achievable. And so I think it's a good strategy for those men, and in terms of reducing one's risk of HIV. And for HIV positive men who serosort, certainly reducing HIV transmission to negative partners is a potential benefit as well.
I realize we've gotten well ahead of ourselves also. Can you talk a little bit about serosorting? What it is, the various ways it can be done, the different groups that serosort in different ways, and how that goes about.
Sure, I guess I can start. So there's a few different. So so there's an ever-expanding menu of seroadaptive behaviors, and I think sort of, in my head, I sort of divide them into more traditional seroadaptive behaviors, which includes serosorting. So serosorting is the idea of choosing one's sex partner based on your HIV status and your potential partner's HIV status. So for example, for HIV negative men, maybe they choose to only have sex with HIV negative partners, and either not have sort of HIV positive or unknown status partners at all, or if they do, they might always use condoms with those partners and maybe have sex without a condom with their negative partners. But there's sort of an array of things that expand from that. So behavior called strategic positioning, whereby for example, an HIV negative man, if he has sex with a positive partner, he would be the inserter partner, he would top that partner. But if he has sex with a negative partner, he would bottom that partner, he would be the receptive anal sex partner. So it's sort of this expanding menu, but the rough idea is that for an HIV negative man would be to reduce the risk of HIV, for a positive man would be to reduce the risk of HIV transmission.
And I think it's interesting in the light of some of the results of this conference that we can actually see some of the new biomedical strategies in this same light, because this is what gay men do to reduce their risk of transmission while having unprotected sex. And in the same way, you can see treatment as prevention as a form of seroadaptive behaviour, because as a positive man goes on treatment to control his risk of infecting others, or it may be one of the things he takes into account when he goes on treatment, and that makes him feel better about having condomless sex with other people. And the big news of the conference, of course, is that pre-exposure prophylaxis works very, very well in gay men. That's another behaviour a man can adapt, taking daily antiretrovirals to avoid the risk of contracting HIV when having condomless sex.
I was going to bring that up actually, because I was just thinking about this in the context of prevention and prep for prevention, and we were just having a community meeting where we were talking about basically prep works when you're maybe unrealistically adherent at this point, although we're working on trying to figure out if there are different dosing schedules can help with that. But I know from discussions with people in the community, HIV men who serosort using online systems and online profiles for dating, that PrEP has become a tagline basically for safety, for I'm a seroadaptive type person. And can you talk about that? Does your work ever look into behavioral context in that way, where you're looking at what actual strategies are being adapted out there in the wild?
We try to keep a pulse on sort of the changing behaviors, and have noticed recently on some online dating or hookup sites that undetectable has been on there as a category for a while, and negative on PrEP is sort of a new category. So we try to keep keep a pulse on changing behaviors as much as we can and incorporate them into what we're doing, just so we can have a better understanding of some of the strategies men are adopting to reduce their risk of acquiring or transmitting HIV, and sort of understand how prevalent these are and sort of the risks and or benefits associated with these. So we actually have an ongoing study in the STD clinic trying to capture a lot of these seroadaptive behaviors so we can get a better idea of the risks and benefits of these. So one of these is PrEP. So we're trying to understand if men are talking about PrEP with their partners, positive and negative, and for those men who are on PrEP, if they're sort of taking that into account with their sexual practices, and if HIV positive men are asking their negative partners, are you on PrEP, and making decisions about using condoms or not using condoms based on that information. So we just actually started collecting that information in January, so we don't have a lot of results to share, but in terms of something that you were mentioning, Andrew, with undetectable viral load, at least in our clinic in Seattle, we find that about 60 to 70% of HIV negative men who have had positive partners in the last year are making decisions about not using a condom based on whether or not the partner is undetectable, and which I think is interesting and just sort of affirms this idea that sort of expanding potential partners based on your PrEP use and if your partner's undetectable and all those things. So we are trying to do our best to stay ahead and try to really make sure that we're incorporating some of these new strategies into our practice.
And if I could add there, it's not just about choosing to have more partners. So in our Serosorting couple study, we find that the couples where the viral load is undetectable do report, not surprisingly, much more condomless sex than the couples who have detectable viral load. And so they're making the decisions about the sex they have within their relationship based on the viral load.
Exactly.
But I like what you said, Christine, about risks and benefits, because we have to remember with all of these behaviours, it is condomless sex, and although this does address to a large extent questions of HIV transmission, it absolutely does not address questions of STI transmission. Mm-hmm. And there's a lot of work out there that suggests that increases in serosorting in positive men has really contributed to the syphilis epidemic we have raging around the world in gay men at the moment. Research that we've done in Sydney shows that that positive men who engage in seropositioning, so they tend to take the bottom position more, have a lot more rectal STIs than men who don't. Mm-hmm. Now, that's not surprising, but it happens. And as all of these behaviours increase and gay men use less condoms, I'm afraid we will have to deal with the consequence of increasing STIs. That means visiting doctors more often to get tested. Mm-hmm. Lots of these conditions are asymptomatic. If people are tested and treated quickly, and maybe we can control this epidemic, but frequent testing has to be an important part of this for HIV and for STIs.
Mm-hmm.
Right, so you can't push in one spot without another popping out.
Right.
Is there any work being presented here at this CROI that is talking about the kind of correlation between these other STIs and serosorting behavior?
I'm not aware of research presented at this CROI, but there's certainly good work out there that STI rates do increase when you get serosorting. Certainly syphilis in positive men, rectal STIs for seropositioning in positive men, urethral STIs, the opposite for HIV negative men who top all the time. So, as sure as night follows day, that will happen. Testing is the answer. Or, we mustn't forget some men actually find condom use relatively easy and relatively straightforward, and that will protect them against both HIV and STIs. And we must never forget that a very substantial proportion of gay men find condom use not a problem. Mm-hmm. And we've got to support those men who make those choices, because they're certainly contributing to both HIV and STI control in our community.
That's a really good point. Mm-hmm. There are heroes out there for prevention, champions. So let's talk a little bit possibly about any other topics at this year's CROI that are intriguing to you.
For me, I think some of the results presented yesterday regarding PrEP use were really interesting and sort of reaffirm what we know, that PrEP is effective, and that if it's properly adhered to, or even with this intermittent use, it can be ineffective. tool in the toolbox of prevention strategies. I think one of the questions that has come up a lot is sort of the rollout now of PrEP, and it's been a big topic as well, and how do we do this efficiently and in the context of our healthcare system. And in our STD clinic here in Seattle, we do have a PrEP clinic that's part of our STD clinic. And we're fortunate enough that the state has Washington State has a drug assistance program that if insurance, if there's a copay, our Washington drug assistance program will pick up the copay. Medicaid does cover a lot of the medication. Again, the Washington drug assistance program picks up the copay, or will cover a medication if it's not possible for people. And we're well staffed in that clinic in that we can help people navigate through the system, which is incredibly complicated. And so I think that we're sort of, it's starting to gain hold here in Seattle, but we have this benefit of the drug assistance program, and we have the benefit of having staff who can help people navigate their way through the system, and I think it's kind of a unique setting for that. So I think outside of Seattle, and I'm not sure about the system in Europe and Australia, but trying to get PrEP rolled out, it's really sort of the question that's been spinning around in the conference.
Yeah. So globally, I'm afraid we're not as advanced as you in the US, and it largely relates to drug costs. In countries like Australia and most of Europe, where the government pays almost the full cost of drugs, governments are simply not prepared to pay in the order of $10,000 a year for a preventive agent. It's going to come down to cost. Within a few years, we'll have generic Truvada. We don't want to wait a few years, of course. It's just not acceptable, and we will need to find ways to deliver it. We need Gilead to file to get this drug registered outside the US. It's simply not acceptable that Gilead's trialling the study around the world but not registering the drug. And because once it's registered, then we can start the process. I do understand that Gilead is making moves in that direction, and I really support them doing that, and that's really good news. But I think the big news that we'll remember CROI for is intermittent prep. And I know there's going to be a clamour out there in the gay community about what is it and can I do it now. So it's worth just emphasising the regimen that was taken in the IFARA study, which is the study that found this effective result. It's 2 tablets between 2 and 24 hours before sex, followed by another tablet the day after and another tablet the day after. So it's 4 tablets. It's not just 1 tablet and go partying. There is absolutely no evidence that that will work. There are still some questions about the regimen, because in IFARA, the men were taking on average 4 tablets a week, which means the drug builds up in their system. And if a man wants to know, can I go out on a weekend or a big party weekend and take this 4 pills in this way, I really want to see the results of this study in a little more detail before I would be confident in recommending that to my patients. The study will be published very soon. I'm sure there's going to be a lot of interrogation of the results over the coming weeks and months. For the moment, I think we have to emphasise that the safest way to take PrEP is every day. We have a really hopeful way of intermittent PrEP, but personally I won't be recommending it until I see the results in great detail.
And there is a lot of talk about PrEP, and it's probably because of the IFARA study, and it's recently being published. But in this conference, I also notice a lack of discussion about post-exposure prophylaxis and the role that can play for emergency situations. And in post-exposure prophylaxis, I think of it that it occupies this interesting space where it's a last resort. PrEP can be part of a lot of other opportunities for prevention, like serosorting and like condom use and clean needles, etc. But PEP is just within this one little narrow window, and it's all alone out there. So is there anything going on in terms of behavioral use for PEP, or you can maybe speak to what's happening in Seattle and Washington about a PEP program or any kind of outreach that's being done around that?
Yeah, I can't speak too intelligently about PEP. I know that in our setting, our clinic that sees mostly HIV positive patients they do prescribe PEP, and if patients come to the STD clinic, we refer them there for PEP, where they're evaluated for their risk and then prescribed PEP if the risk is deemed adequate by the physician who sees them, or the person just really feels that it's sort of a one-on-one decision about it, just really feels more comfortable if they had taken PEP. So I think you're right, PEP still fills this, in a way it got pushed to the side because PrEP is new and exciting, and taking a pill every day to prevent HIV is more appealing to some people than waiting until after a potential exposure and then needing to go in to see somebody to get a prescription for that. I think there's a couple of sessions on PEP specifically, and there might be one today or tomorrow, I can't remember. I think it's entitled PEP Remember Me, which sort of fits that, that sort of feeling that you were discussing about it. But I can't speak too much about PEP, except that I still, for some people, it's a great tool again to have for people who feel that they were exposed and can access PEP in the window necessary for it to be effective.
So I can talk a little bit about PEP in Australia, because we've used it very widely for a long period of time. It's been promoted widely in the community. We've studied it in our cohort studies. The issue is, because it's a one-off treatment of a 28-day courses of pills, people tend to maintain their risk behaviour and often become infected in the future. So we've had a cohort study which showed that people who take PEP, it works, and follow them into the future, and we find they have very high rates of HIV infection in the future. And really, these are people who need to be on PrEP because they've got a pattern of behaviour, and PEP covers those single events very well if they get to the doctor in time, and it should, we always promote it in Australia as quickly as possible, even though the guideline says within 72 hours, sooner is better. So, if people in that situation, they should try to get it if they can, but it's not going to protect you in the long term.
Right. It seems like it's more of a linkage to care issue. If you have someone coming in for PEP, perhaps now is a good time to have a talk with them about considering PrEP and other options.
Absolutely.
Definitely.
Yeah. Well, I think that we've had a really interesting and sort of circuitous but very tight around seroadaptive behavior discussion, and I think that our audience will find it to be really illuminating. So thank you both for coming so much.
Thank you.
Thank you.